look at it now, again, what may be confusing is if she had a lateral shift, I'm accentuating the lateral shift, right? She's doing right side gliding, which would accentuate the shift. But in my mind's eye, there's no relevant lateral shift. She has a relevant lateral, maybe a relevant lateral component. So I'm squeezing that side down, closing that side down. And the fact that she feels better afterwards, in my mind, confirms that it was a relevant lateral component and not a lateral shift. Because I'm accentuating the lateral shift, and if that was a function of her pain, she should have been worse after. Now, maybe I do this and she gets worse. Well, then maybe there is something to this shift, and we got to correct the shift. But that didn't seem to happen. Every patient that's a derangement that has an asymmetrical or unilateral pain pattern has a lateral component to the derangement. We're in agreement with that? If it needs to be addressed because the patient does not respond to the sagittal plane, that lateral component now becomes relevant to their treatment. Relevant lateral component. You have a relevant lateral component to the nth degree, that will cause a deformity of a lateral shift. Big lateral component, big relevant lateral component, lateral shift. Relevant lateral shift. They're confusing terms. It's just, you've got to get used to using them correctly. Use them correctly. And I promise at Part B, people will ask the same questions. You may have it solid in your head, other people won't. Part C, we have the same questions. Part D, it's just, people think they hear it right on Part A, and they use it wrong, and they got to be straightened out. It's always the same questions and concerns. So